Hello, my name is Jeff Weiscarver, and today I'm going to be talking about screening for bruxism and sleep-related issues. And I'd also like to take a moment to thank Jamison Spencer for giving me the opportunity to present this information. So first I'm going to talk about sleep bruxism and its definition. And I refer to Dr. Jill Levine's research from 1996. And in that article, he had the nice, concise definition, which I'll share with you. And they talked about a clench being an EMG burst of at least a quarter of a second, but less than 2 seconds. They talked about RMMA, or rhythmic masturbatory muscle activity. And RMMA is actually a series of low energy bursts that are at least a quarter of a second, but less than 2 seconds each. And then there is a grind, and that's a combination of those two events. Here's an example of RMMA, and you can see it's almost a series of twitches, low, short, concise, tight little events, and they're actually fairly common. Next is a clench, and this clench, this is how most of us imagine that a clench looks like, and you can see here that the clench has a pretty standard appearance. And then the grind. The hallmark feature of a grind is its duration, and it's a little deceptive here. This is a minute and a half window, and so that event is like 15-20 seconds long, which is much longer than the other two events that I was talking about. So I've defined what bruxism is, and there's a nice concise definition, and now I want to talk a little bit, add to that parafunction. And the reason for that is there are EMG events that occur that don't fit the bruxism definitions. So parafunction is a little bit bigger bucket, and for the rest of this presentation, I'm going to just talk in terms of parafunction, which includes clenches, grinds, and RMMA, and then those events that kind of fit outside those categories that we measure when we measure EMG at the masseter while patients sleep. Okay, so what are we talking about exactly? And bruxism and parafunction are, we think, the result of an EEG arousal from something. It doesn't necessarily have to be any specific thing, but there's an EEG arousal, and that EEG arousal triggers a series of events, change in sleep stage, increased heart rate, increased blood pressure, and then also it can trigger an EMG or parafunctional event. So this is what we see when we do full PSGs as well as home sleep studies that measure for parafunction. Okay, so what's the most common EEG arousal? Sleep disordered breathing. So I'm going to spend some time talking about that. And here is one of my favorite slides that I talk about. And on this slide, we have 6 phases of a diminishing airway. And I'm going to go through each phase, and I will say that during any one of these phases, an EEG arousal can occur, and then a parafunctional event can result. So phase 1 is flow-limited breathing. And what happens with flow-limited breathing is it occurs during inhalation, and the airway aperture shrinks at some point, and that creates a reduction in flow, and we can see that in the flow signal by the signals topped off. And then the other thing that we know is on the other side of wherever the flow is restricted, we get negative pressure. So the airway kind of sucks in or draws in, and now we're going to go to phase 2, which is snoring. And what happens a lot of time is when you have this negative pressure, the soft tissue draws in, and we start to see snoring. And here's a great example. It's the bottom channel there of crescendo snoring. So now we have flow-limited breathing with some negative pressure and the vibrating tissue all combining to go to number 3, which is increases in respiratory effort. So RERAs, respiratory effort-related arousals, occur around this increased work of breathing that causes an EEG arousal and can cascade into a parafunctional event. So with that in mind, we're going to go to number 4. And this event here, we're talking about a frank hypopnea. That's the H in AHI, the apnea-hypopnea index. And in conjunction with that hypopnea, there's an oxygen desaturation. And obviously what's happening here is we have a reduction of intake of air. And as a result, we didn't get enough to oxygenate all the tissue, and we start to see a depletion of the oxygen in the blood. And that's what the desaturation is. And this event number 6 terminates in a clench. So this is how this can all be related. Okay, looking at the next slide here. This is a kind of an upper airway resistance event. And what we have here is a series of flow-limited breathings marked by the little orange boxes on each breath on that one channel that you see. And then you see a clench. And on this clench, it meets the definition. It's at least 1/4 of a second, but it's less than 2 seconds. And then interestingly, in Jill Levine's research, he liked to have video or audio confirmation of the bruxism event. And in this case, we did get the audio. We did catch the audio. And you can see that on the bottom channel, there was an increase in the audio, and that's not what snoring looks like. That's what teeth rubbing together looks like. Okay. Okay, we were just looking at a minute window, and now we're looking at a 30-minute window. And you can see, what 30 minutes looks like in one of these patients. So I'm going to talk about this from two perspectives. One from the dental sleep medicine perspective, and then this other will be from the orofacial pain TMJ specialist. So from the dental sleep medicine specialist, you can see on the flow signal that has all the orange and blue boxes. Those are apneas, obstructive apneas, and hypopneas. And you can look in the 30-minute window, you count in all those boxes in 30 minutes, and that's a very severe apnea, and you would be absolutely right. But if you're a orofacial pain specialist or a TMG specialist, the channel just above that, you see a ton of parafunctional activity. So if this patient has, let's say, TMJ symptoms or complaints, and we can see the amount of parafunctional activity in just 30 minutes, and you multiply 30 minutes times all night times 7 nights a week, you can see why these patients get symptomatic. And if you don't know what's happening while they sleep, you can see why sometimes these are very difficult patients to deal with. Okay, so I'm going to shift gears a little bit. This slide here is going to be focused more for the general dentist and the orofacial pain or TMJ specialist. And what we did here is we did a 2-night study on patients that did not get treated for any type of sleep disorder breathing, but were treated for either worn dentition or TMJ symptoms. Okay, so we did 14 subjects. Baseline, and then with whatever treatment was prescribed. And if you look at patient 14, we have an AHI of 0.8, and then with them wearing the guard, the AHI kind of goes up to 1, which is nothing. I mean, if you're not familiar with the AHI, those are negligible numbers, any way you look at it. So whatever we were treating with our therapeutic intervention, great. It did not have a negative impact on the airway, and that's a beautiful outcome. But if you look at, let's say, subject number 8, where we started with a mild, almost moderate, an AHI of 13, and then with the guard, the AHI went up to 25.5, which is almost severe. And that is not a great outcome. So really, you'd have trouble justifying prescribing that guard, because of the tremendous negative impact it had. Patients not breathing with it in. And if you've ever wondered why patients can't breathe well with their guard, sometimes this is why. It impedes their breathing. And moreover, can you what treatment would justify this kind of impact on the airway? But the problem is we don't know a lot of times. We don't know that this is the impact. Okay? All right, so what's the solution here? What's the answer? And we at DDME created a product called the GEMPro. It's a dental test unit. It is not an HST. It's not doesn't diagnose sleep apnea. You don't get an AHI. It's none of that. It's a dental instrument. It has an oximeter, and then it has that's the kind of the purple thing there. And then we have a little amplifier. The oximeter does SpO2 and heart rate. And the amplifier does snoring, parafunction, and body position. So body position is a great thing to know, especially for you dental sleep medicine specialists. For you, body position can be a very important component to treating your patient. So how the GEMPro works is the patient wears the oximeter and the amp to bed, the tablet somewhere in their house, and those two devices transmit their data to the tablet throughout the night. And in the morning on the tablet, the patient clicks send study, and then the tablet uses Wi-Fi to send you, the dentist, a report. We're going to talk about those reports now. So here's a sample report. The top graph is SpO2, and again, the color of the graph indicates body position. So red is supine, green and blue are left and right. And we can see here that this patient has some amount of oxygen desats. The second graph is heart rate. The third graph is the bruxism or parafunction, and we're going to spend some time talking about that. And then the fourth is the audio sound. And we call it audio because we have a really cool feature that we can listen to the parafunction. And I'll talk about that and show you a really cool graph here in a minute. Okay, so let's talk about parafunction. So with the GEMPro, we report parafunction and bruxism on two vectors, magnitude and frequency. And a lot of people say, oh, how can you do that without anything in the occlusal plane? And what we do is that tablet I showed you has this page, it's like animation, and it will say bite down as hard as you can, bite, 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 and then relax. And then we'll measure the force based on the amplitude of the masseter EMG. So the higher the amplitude, the harder you're biting down. Okay, so that's how we get that value. And then once you go to sleep, we compare the maximum waking bite force to the forces generated while the patient sleeps. So that's how we get our magnitude numbers. And it's very easy to do. It's a great way to do it without interrupting the patient's sleep. And at the end of the day, we have a scale here. We have a ratio, meaning we divide the waking bite force and the sleeping maximum value, and we get a ratio. A ratio of 1, meaning that they're biting down just as hard while awake as when asleep. That's mild. So anything below 1 is normal. So 1 is mild as far as force is concerned. 2, meaning you're biting down twice as hard while asleep than when awake. That's moderate. And 3 times as hard, is severe. And when you're talking to your patients, a lot of times patients aren't aware of this and they'll deny that they have a problem. But when you say, remember when you bit down, on the tablet, had you bite down as hard as you can? When you sleep, you're biting down 3 times as hard as when you're awake. And they'll be able to relate to that. They'll have something they can relate to. Okay, let's take a look at a graph. So on this graph, we have biocal max, the max waking of 102. See they're kind of in the middle on the right. And just above that is the maximum sleeping force, which is 105. And the ratio is about 1. So that's why I chose this graph, because it was almost a perfect 1 score. So the magnitude is mild, but on the bottom underneath the graph, we have the frequency. And the frequency, the first 2 boxes, 133 and 90, those are pretty weak parafunction. We have a very sensitive instrument, and it can pick up events that don't even have tooth contact. So those first 2 boxes are not of great concern. The next 3 boxes at, say, 35, 7, and 5, each one of those boxes, or I call them bins, those events are stronger and stronger, okay? So we have a fair amount of parafunction with this patient that's of mild magnitude. And the graph on the bottom, the blue graph, is their calibration that they did before they did the study. Okay, so let's take a look at a full report. So this is a patient that is not asleep, there's no symptoms or complaints of sleep, but they have worn dentition, and the dentist wanted to see what was going on, and so they did a GEMPro study, and the airway's fine, as evidenced by the SpO2 graph. The top graph is normal. There's the lowest DSAT was 90, and that's really a normal outcome. And the bottom graph, the snoring, there was no snoring either. So we just confirmed that there wasn't any lurking, obvious airway issue. And then as a dentist treating a patient with wear, we can go ahead and proceed with whatever therapeutic intervention you want to prescribe. And then what we recommend is once you do whatever it is you do, do a second study to make sure that that airway is still fully functional. Okay. Here's another kind of study. This is, again, the colors of the graph is body position. So you look at that top graph and you see where it's gray and red. That means that the patient's on their back. And you can see there's a very severe desats while the patient's supine. So this one's actually pretty easy. I know the graph was kind of busy, but if you look at the bottom graph, they're snoring like crazy. And we have very severe desats. And in fact, if you look at the heart rate, you see a lot of Brady tachycardia there, which is kind of interesting. But in any event, this is an obvious medical patient. So we need to get this patient seen by a physician, get them diagnosed. There's a variety of ways to get a patient diagnosed by a physician, and you would put this patient in that track in your practice, okay? Okay, so I did want to say a word to the general dentist. And the general dentist, sometimes they get a little bit leery about screening. ADA and other dental organizations are all saying you guys need to be screening for airway, sleep disorder breathing. And there's a fair amount of apprehension there, because in the cases where you get an outcome like you're looking at now, this is a very severe apneic, oxygen desaturations to 77% frequently. And so what is a general dentist supposed to do here? And it's real simple. Get them to a sleep lab or to a pulmonologist. Because, print out the GEMPro report, say get to a sleep lab, and you have a very serious medical problem. And next time I clean your teeth, I'll be asking you how your appointment at the sleep lab went. Something along those lines. Okay. We're going to talk now a little bit about snoring. Snoring, we have 3 graphs here. The top graph, we have a patient who is basically sleeping on their back. The gray part of the graph is them on their back but propped up, and then the red part's when they're supine flat. And you can see when they're propped up on their back, they do pretty good, but when they go flat, the bottom falls out. There's profound snoring when they're on their back flat. And you can see kind of a little later in the night, they go back up and the snoring is almost completely resolved. The middle graph there, there's no snoring. Once in a while you see a spike, and those are normal, probably body position changes or what have you. And then the bottom graph there is a dentist that tried out the GEMPro just for the heck of it and learned that they are a really bad snorer. In fact, I get a copy of all the GEMPro reports, and this is the worst snoring patient I've ever received, and I've received thousands, literally thousands of these GEMPro reports. And a dentist got the award for the most snoring. Okay, so we're getting close to wrapping up here. Bruxism analysis. This is not duplicate graph. This is 2 separate graphs. One is the bruxism, the top graph. The bottom graph is the audio. So we're listening to the person grind their teeth. That's one of the cool features about this is you can really listen. It's a very sensitive instrument, like again. And if you have parafunctional activity, a lot of times when you can hear it, here's the impact this has. Try making noise with your teeth. And it's not easy. In fact, it's painful for most of us. And when you see this loud of tooth noise, you know what's going on during the night. And sometimes that's a good way to get through to your patient if they have any kind of denial of the problem. And here's a report here. Patient had pretty normal airway, low desat of 88, but they had really bad parafunction. Their magnitude was about 4, and so the dentist made them a guard. There was no snoring, very few desats, 1 or 2 desats throughout the night. So the dentist made a guard. It actually stabilized the airway, and it reduced all the energy to almost nothing and eliminated the frequency. So this is a great outcome. And you can show your patient how well they did with your therapy. It gets them motivated, again, to be compliant. And wrapping up here, this is a dental sleep medicine patient. And we learned a couple things using the GEMPro that we would not have learned using other screening techniques, whether it be high-resolution pulse oximetry, if you're into that kind of thing, or a regular oximeter or what have you. Is with the GEMPro, you get additional information like body position. this patient sleeps the whole night on their back, which is rare. And there's a reason. The patient had an injury and they need to sleep on their back. And they're anapneic. And so the other thing that we learned is that they have profound parafunction. They're severe. They're in the severe category. So would you want to make this patient like an EMA? This patient would probably eat an EMA. Okay, so at the end of the day, here's what we learned from the GEMPro that we would not have learned from any other type of screening device. Again, this is a dental screener, not an HST. Is we learned that, one, the patient sleeps on their back all night. Two, the patient has excessive parafunctional activity. And three, they're very high likelihood to have sleep apnea, okay, because they have a AHI oxygen desats to 81%. So that's pretty severe. So now we know what we're dealing with. You send the patient off to get diagnosed. We know that we can't get them off their back because they sleep only on their back. And we're going to make them a robust appliance, okay? All right, so I wanted to wrap up by saying thank you first. I wanted to mention the GEMPro retails for $1,900, but if you give me a call, my phone number is there, my email address is there. Love to hear from you, and I'll give you a really nice discount as a result of attending this seminar. Okay, thanks.